postoperative pulmonary complications, which is why we're here today. And I wanted to just say a few words about them. First off, pulmonary complications postoperatively are fairly common. In fact, they're the second most common postoperative complication, following just surgical skin infections. That's the most common. And there's an estimated incidence of about 5%, although there's a very wide range depending on the definition and the type of surgeries. So for instance, in lung surgery, it can be as high as 60 or 70%. They're also very costly. They cost the patient because patients end up in the ICU more frequently, and they lead to longer hospital stays. And they also have a very high mortality associated with them besides the morbidity. About 1 in 5 patients who develops a postoperative pulmonary complication will die within 30 days of surgery. So there's a 20% mortality, 30-day mortality associated with pulmonary complications in the postoperative period. Now, there are a lot of reasons why people can develop postoperative pulmonary complications. Today, we'd like to focus on one of the factors that we can modify in the operating room, and that is how we provide mechanical ventilation to these patients. There's an increasing awareness of the role of mechanical ventilation in the development of postoperative pulmonary complications, and specifically high tidal volumes and low PEEPs have been demonstrated repeatedly to be issues with pulmonary complications occurring. The evidence in the literature is also expanding, and it's showing us that tidal volume and driving pressure and the values of those variables can be associated with the incidence of postoperative pulmonary complications. And so I think it raised a lot of questions for people reading the literature recently. What is the evidence that how we ventilate patients in the OR is associated with pulmonary outcomes? And how can we modify our practice to reduce postoperative pulmonary complications? So we're going to try our first audience polling. So if you take out your smartphones and see if this works. And I might need some help from the technical people. Here we go. So, are you currently practicing lung protective ventilation? Yes, no, or you're not sure. And we have 15 seconds for you to enter your answers. Three, two, one. Okay, let's see. Okay, great. So I probably don't need to say much more about practicing pulmonary ventilation. We have 75% that are, 1.5% who are honest, and about 20% who are like me, we really weren't quite sure if we were doing it or not. Okay, well, thank you for those answers. We'll continue. We weren't quite sure ourselves and decided to put together a little group of people to discuss these questions and come up with some recommendations concerning lung protective ventilation. And as you can see here, GE and Duke Anesthesiology partnered for a forum in which we tried to answer some of those questions. The process that we engaged in this was to identify research teams and physician experts to help us answer these questions. And we developed research questions that we thought were pertinent to the issue of postoperative pulmonary complications and protective lung ventilation. We then performed a targeted review of the literature and produced an initial set of recommendations for questions based on the literature. And after that, we then met, as you saw in that previous slide, in a face-to-face meeting back in October to discuss and revise the responses, and then using a modified Delphi approach to vote on the strength of the evidence that's available out there in the literature today. And we hope to publish those recommendations. The manuscript describing the entire process is currently under review, and hopefully will be published soon. Just to show you, we had a number of researchers who did the preliminary work on looking at the papers, and this doesn't project very well, but basically they started off with about 7,000 citations from PubMed, almost 10,000 citations in total, that were screened down to a total of about 200 plus articles that were full text articles that were used for the actual consensus conference. we gathered our set of experts, some of whom are on the stage here this afternoon, and went through this process of evaluating each of the statements and moving through the statements. We had a first round of voting, and if there was complete consensus, which there never was, we moved on to a 1-minute explanation by the researchers, which is that center box there, and then moving to the left where the number 3 is, a brief discussion among the experts. It was generally longer than 3 minutes, and a reformulation of the statement or recommendation as needed, followed by a second round of voting, and then a final consensus count. And if 70% or more of those experts agreed on a recommendation, it was accepted. And if it was less than that, we decided that those were things that still needed more study before we could reach any consensus on. As a result, we had 24 questions that were researched, and recommendations were produced before the Delphi meeting and the face-to-face meeting in October in Frankfurt. And the discussion occurred then, and it resulted in 22 recommendations and 4 statements. 2 recommendations overall did not receive the 70% consensus, and so those are not ones that we're going to be recommending at this time. So among the experts that are going to be speaking today then, and you probably want to say, well, what are those recommendations? And that's what I'm going to leave for these next group of experts to tell you about. So first, Dr. Foutier will be presenting on the case setup and induction of anesthesia. He's professor of anesthesiology, critical care medicine, co-head of the Department of Perioperative Medicine at the University Teaching Hospital of Clermont-Ferrand. And he's had multiple research interests in lung protective mechanical ventilation and perioperative optimization in high-risk surgical patients. So he will go first, and following him, Dr. Pelosi will come up. He is Chief Professor of Anesthesia and Intensive Care, Director of the Specialty School in Anesthesiology at the University of Genoa. Also the most recent recipient of the McIntosh Award. Congratulations on your talk this morning. Past president of the ESA, and has a number of research interests, including in the respiratory area as well. And then Dr. Galma de Abreu will be speaking. He is the professor of anesthesiology, intensive care medicine, and vice head of research, director of ARDS and ECMO program, and Department of Anesthesiology and Intensive Care Medicine, University of Hospital Carl Gustav Karls in Dresden, Germany. So with that, I will, and he will be presenting lung protection on emergence from anesthesia.